Thanks, Mark, for joining us today. Congratulations to the Mavs for making it to the playoffs and
Well,
doing
we're
well.
not quite there yet, so
Yeah,
hopefully, yeah, hopefully
but
today and tomorrow.
that's right. You've had a really good run. I'm expecting you to be there. So I, know that you won't be able to make the conference in person, likely because you'll
Right.
be at the playoffs. So I appreciate you taking a few minutes today to share your thoughts with us. Um, so you started the Mark Cuban Cost Plus program. How many years has it been and why did you do it?
Well, I actually got a cold email from my partner, Dr. Alex Oshmayansky, and he wanted to start a compounding pharmacy in Denver. And the more we talked about it, the more I realized this was a much bigger opportunity. He wanted to do generics that were in short supply and compound them. I'm like, the more I dug into it, the more it was obvious this was not an efficient market. There were a lot of indications that the lack of transparency was the foundation of the problem. So, as time went on, we got to the point where it was like, okay, let's create this company, Cost Plus Drugs, and let's make the foundation of it, the core of it, that we're going to be completely transparent. We're going to show our costs. We're going to show our markup. We're going to show our price. We're going to show shipping, all the things that, no one ever showed before. We'll make our price list available. So we worked on that for a few years, and we finally launched and started shipping to the public on January 22nd, 2022.
2022. Excellent. And so how many drugs do you have now? And initially you started with like a handful, but now you've got
Right.
tons.
Yeah, we started with like 100, and now we've got 2,500 SKUs, of which 10 we're dealing with 10 brands, and that the number of brands is growing by the day as well.
Awesome. Well, congratulations on that again. This is a price transparency conference. We love your model. We want the whole industry to move to a more transparent model. Um, Okay, so I testified in Congress in June. I saw that
Uh-huh.
you recently testified or shared your thoughts with at the White House. Tell us a little bit
Uh-huh.
more about what you shared with folks as far as recommendations for employers.
Sure. When you look at the industry and try to figure out, okay, we have this problem. Everything's opaque. It's like the number one rule of drug pricing is you don't share your contracts, right? You don't talk about your contracts.
Right.
And, to me, that's the number one rule to fix the industry. One, having employers say, okay, the requirement for me doing business with you, whether you're a BUCA or a PBM of any size, is we're going to publish our contract, because the more transparency for our contracts, the more businesses of all sizes can learn, and we all can become better at what we do. Now, there's a lot of the bigger organizations that don't want anybody to do that for obvious reasons. But when I sat at the White House, I started giving examples of the challenges that occur because of this lack of transparency. There'll be things like formulary control, having to do full price Humira or Humira minus whatever rebate you get, as opposed to biosimilars. So, the retail price of Humira might be $7,700 a month, give or take. And after rebate might be $2,000. But there's biosimilars like Coherus that Cost Plus drug sells for $594 a month, and not adding that to your formulary is crazy. Then there's the side of the pharmacy. The way it works right now with the BUCAs and the big three PBMs in particular, that when you go to fill a prescription for a brand medication at a pharmacy, there's a really good chance that the price that the pharmacy is being reimbursed for is less than what they paid for it. And that's just not sustainable. And when that's not sustainable, that creates a lot of second level problems where, grandma or Susie or your son or daughter has been working with the same pharmacist for 25 years, and they know exactly what medications you're taking, and you want that personal attention. Or the bigger problem is they can't afford to do it. They're losing money on all these scripts, and they're going to go out of business. And if they go out of business, a community can become a pharmacy desert. And this is all because of the contracts that self-insured employers are making with the BUCAs and the PBMs. And so my message was, employers in particular, and states with their Medicaid deals, and states with their approvals on Medicare Advantage deals, have got to stop using the big three PBMs and, at least the BUC, in some cases the BUCAs as well, because that's the core of the problem. if the companies would just start working in their own best financial interests and in the fiduciary and healthcare interests of their employees, then this would all change. That, you know, we all turn to Congress and say, okay, we need legislative changes and this needs to change. And there's some value to that. But the reality is, if self-insured employers would just pay attention to what they're doing and just look at their pricing and ask for pricing and do things like, you know, say for any contract, any contract that we do with a TPM or TPA, with a PBM, with a BUCA, we're going to publish it. We're going to publish it so all of our peers can see it. Two, if there's rebates involved, and you know, we think it's better you don't do rebates, but if it's rebates involved, we want to make sure that we're able to audit those rebates each and every year. Because what we're finding is a lot of the big companies that try to do big rebate deals, they're not even getting the rebates that they're contracted for. And what I'm telling the big employers is to realize that the people who pay for the rebates are not the manufacturers like the PBMs tell you. They're your sickest employees. Because when you take a rebate back, your deductibles are a little bit higher. Your co-pays are a little bit higher. Your co-insurance is a little bit higher. And who has to pay up to their deductible? Your sickest employees. Who has chronic illnesses and they have co-pays and co-insurances all the time? Your oldest and sickest employees. And the last thing any CEO, CFO, HR person wants is their name in an article in the Wall Street Journal saying, you know, this group of employees filed a whistleblower report because their deductibles were too high, because they saw in your financial reports that you were getting X number of millions or tens of millions of dollars in rebates. And so, you know, the list goes on from there, but there are so many things, you know, asking for daily, weekly, or monthly claims reports. It is just insane that as a company that self-insures and you're trying to understand what your healthcare costs are, your second biggest expense line item after payroll, you're trying to understand that more and maybe come up with programs to improve the wellness and reduce your costs. And you know what it's like to try to get your claims from your TPA. It's impossible. You have to fight, you have to pay. And even crazier is the manufacturers can't get that data either. So nobody has that data from the PBMs unless you scream, yell, you know, get upset and pay for it. And then of course, there's prior authorization. So here you are paying for the welfare of your employee and trying to get, you know, their health and wellness to be as good as possible. And the company that you're paying to deal with your healthcare is telling you, no, the doctor that they recommended in their network is saying that, you know, you're the son or daughter of one of your employees is sick and needs this medication and they want to do step-up therapies, or they won't authorize it, or they're just saying no on a pre-authorization request. And what happens then? Well, you have an upset employee because their son or daughter is sick and they can't come to work because they have to deal with it. They're dealing with the HR department who's trying to figure out why the pre-auth was denied, who is then dealing with the insurance and or PBM, who's trying to figure out, you know, who's trying to keep that claim denied so they don't pay for it. It's just insane, right? Okay. So every employer should have control of the pre-auth. They should have final say. Now, sometimes, you know, I understand that the employer is going to want the PBM or the TPA to do that because it takes the pressure off of them, you know, because there's certain things you might not want the GLP-1s included, right? And you want them to be the bagger. Okay, I get that. But, you know, a kid needs surgery and you want to send them to 3 different doctors and, you know, the doctor's asking for surgery. No, the parent doesn't want to hear about that. Or if it's the employee, you know, the employee doesn't want to hear about that. HR doesn't want to hear about that. They don't want to have to complain about it. Depending on who the employer circumstances are, then the CEO is going to have to deal with it. And, you know, when you come full circle, what all this comes down to is, and I learned this with my own experiences with my companies, the CEOs of companies don't really understand how their healthcare dollars are spent. Yeah. It's not one of their core competencies. It wasn't one of my core competencies. So, you know, when I looked at, you know, when we started Cost Plus, I'm like, okay, I got to eat my own dog food. You know, I've got to understand this because this is the business I'm in now. And I started looking at my healthcare costs. The first thing I looked at was what I was paying an employee benefits consultant, who I thought was my friend. I was paying $30 per employee per month. That was millions of dollars for them to tell me, okay, you're going to go to a BUCA and they're going to use a big three PBM.
Oh, that was
And your
just for
costs
your
are
benefits consultant, that $30?
yes,
Oh my
yes,
God.
it was insane.
Wow.
It was insane.
Well, that's a ton.
Yeah,
So
I was an idiot.
no, you're not an idiot. You know, I often, you touched on so many things that we've been working on here in Indiana and across the country. So I heard employers need to own their own data. Employers need to have unfettered audit ability of their PBM and TPA claims. They need to have independent auditors, right? Not someone internally or with these organizations doing audits. And then maybe engaging the CEOs. So on that last point, it isn't one of the core competencies of the CEOs. And I work with a lot of folks in HR at various levels. And, when their CEOs are supportive, they're fully engaged and can do a lot of this stuff. When their CEOs or CFOs are not engaged, like just spending millions of dollars going out the door and assuming it's just the cost of business, but it's not, right? Be smarter about it, looking at the data. So your thoughts on how to engage the C-suite?
We're at the point now where the money is so big that effectively you either have to promote your HR person to be the chief benefits officer, or you need to find a chief benefits officer who focuses on that. If you're a manufacturing company, you have a head of manufacturing. If you're, a service organization, you have a head of that service organization. And it is such a big number right now for employers. You need somebody whose entire focus is on the cost of healthcare and the wellness it provides, so that you have somebody you can absolutely trust with those numbers. Because otherwise, you're trusting a third party, that benefits consultant, and not all of them are bad, don't get me wrong. But a lot of those benefits consultants are getting commissions on the backside from the PBMs and their captive BUCAs or vice versa. And that's just wrong, and the only way to truly understand that and to be able to deal with your own data, to ask for your own data, to be willing to publish your contracts, to be willing to publish your data, is somebody who's focused on it. And given the number of millions and tens of millions or hundreds of millions or billions of dollars, depending on the size of the organization, or if you're a state, county, city, whatever it may be, it's cost effective. You will pay for that person in a year easily.
Appreciate all of those recommendations for employers. You'll be happy to hear this last legislative session in Indiana. We'll hear more about it at the conference. We established just a month ago that employers own their own data. So, and we
now getting it, they may own it, but who hosts it is a whole different question, right? There's a lot of things that I own that my teenagers have possession of, and I'll never get back, right? And my guess is that, the thing about the biggest, the big three and the BUCAs, they're smarter than us, and they're able to afford. And when I say smarter, they just have so much depth, right, of people and the ability to drag things out, and the ability to afford to say no, the ability to not care. They're big public companies for a reason, and those earnings per share come first over everything else. And so, we've really got to make sure that, yes, it's great that, Indiana Go Hoosiers got all that info, but you've got to make sure that you're getting it on a timely basis to make sure it's worthwhile and usable.
That's right. Usable information. It's what you ask for. You get it in the time that you need it, right? You
shouldn't have to ask for it. It should be a preset report.
Oh, yeah.
Like, yeah, we for my companies now, we switched and we use a pass-through PBM, and I get daily claims reports. Literally, I get to see them. So if there's a medication by chance that Cost Plus Drugs doesn't carry, then I know, and so we can go out and try to get it. Or if it's something that an employee went to go pick up at a pharmacy that's outside of our retail network, the Cost Plus retail network, then we can say, okay, no, we pay too much there. We're next prescription, here's where you need to take it. And we can even incent them. If you keep on doing it your way, you're going to have this copay. And if you do it this way, there'll be zero copay or a less copay. So we can incent them. And so having that daily claims, and it depends on the size of your organization, but literally being able to switch somebody from Humira to Usimri, that's thousands of dollars a month per employee. And just
Okay.
having somebody, just be able to pay attention to that, given it's the most prescribed or the greatest revenue generator of all prescription medications.
Mhm.
I mean, come on, that's important.
It is, right. After 20 years, we finally got these biosimilars and then they're not on the formulary. It's
I mean, the
mind-boggling.
fact that they won't put them on the formulary tells you all you need to know.
Right.
That's it. If you have a PBM that will not put Usimry or other low-cost biosimilars for Humira on your formulary, you should not be dealing with that company. They are telling you everything about how they think about you as a customer.
Well, their pushback might be, and I want your response to this, is that net after the rebates, we're getting you a better deal, but they may not necessarily show you the rebate at the drug level. Your comments?
Yeah, show me the rebate at my drug level, and
Yeah.
why aren't you just dealing with net prices? If it's a better price, just get the better price. Why are you playing all these games?
Right.
It's like saying, well, this airline is cheaper because I got more airline miles. Okay, well, I can estimate the value of the airline miles, but they tell me how many airline miles I got,
Yeah.
and if I don't want airline miles, I just want the cheapest price because I'm only going, one trip a year for vacation. I just want the cheapest price I can get for that trip. So just tell me, just be transparent. And if they're not, or if they play games, or if they talk around it, you're dealing with the wrong company.
You touched on audits a little bit, and I'm curious if you have this level of insight into your audits. So a problem that many of our employers face is they can see a claim, but it's not necessarily what the pharmacy sent to the PBM and what the PBM paid the
Paid
pharmacy.
back, right?
Yeah,
Right.
it's not, they don't necessarily
No, then,
see
then they're not
pay.
seeing the claim. Then they're not
Not
actually
see,
seeing the claim. Yeah,
yeah,
they're
so
not seeing the
those,
claim.
yeah, so what the pharmacy sends in is on a 835 or 837 electronic transaction, and then it
Right.
gets paid on an
Right.
835. Most employers are just seeing what the PBM charged them. So if it came in
Right.
at $1,000, they paid $800.
Well,
They
that's
make
the beauty of Cost Plus, right? We'll send you a copy of our price list,
yes,
and
it's
you get to
online.
see. Yeah, it's online, so you get to see the
Online.
whole thing, right? And so when you get your claims, you're going to see what you paid, but you're going to know based off the drug what you should be paying. That's the value of transparency. And
Right,
if
because you've got the cost of the drug itself plus standard markups and
right, and
fees.
it gives you your chance. If you're getting a good price, then you're willing to pay a fair fill fee to the pharmacy, because if you're seeing your pharmacist, like I said earlier, if they're getting less than they pay to their wholesaler, they're not going to be your pharmacist very long,
Right.
and you're going to have to deal with all those issues as well. But if you're saving money, hopefully through Cost Plus or however you're saving it, and you're getting a net price, then it's okay if they charge you 7, 12, or whatever dollars
Yeah.
it is that's fair to the pharmacist.
Absolutely. Well, I happen to be a pharmacist by background and training, so I
So
agree with you. Yeah, that we
yes.
really need to have pharmacists monitoring drug therapy and engaging with patients. It can't just come in the mail every time. That's not appropriate for everyone.
Right.
Right? Who's going to show you how to administer your insulin and so on. So,
Yep. Exactly right.
okay, so prior authorizations.
Uh-huh.
Hot topic. It's mentioned in our marketplace. We have everyone really on all sides of the issue regarding prior authorizations. I think we understand there's opportunities for improvement with prior authorizations. What are your recommendations for improving the process of PAs?
You set the tone, and you set the process, and you set the rules. Period. End of story. You don't let them tell you, well, we don't think the effectiveness of this, da 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 da. Right. So we just set this. You go through all the pre-authorization rules, and you set them. Right. Now, obviously, the big question are the GLPs. And whatever fits your company, you make that decision. If you feel you have a wellness program that's a better option than a prescription that'll be $1,000 or whatever it may be, okay, that's up to you as the self-insured. But I would also tell you, we're about to see a lot of lower cost options, that are set at net prices. Zepbound, from Lilly will be a lower price, and there'll be others. There'll be orals that come through. And so if you don't have the ability to set your formulary, that goes hand in hand with your ability to do pre-auths. Because if they'll only sell a GLP that is at, a $975 list price, and they're zinging you for the whole, and even if they give you a rebate against it and your net is 700, that goes into your pre-authorization decisions. And if, you can also set terms, well, if you have a pre-auth above X number of dollars, we want to see it because we might decide, because by definition, hopefully it's something more serious. Well, you don't want it to be more serious, but you want to see those things, because if it's a surgery for somebody's child, right, you don't want them to be held up because the insurance company doesn't want to deal with it, or if it's in network versus out of network and determinations of cost, and you want to be involved in those decisions. You don't want to leave those to a third party, because it affects your culture of your organization. The last thing you need is have to just bust your ass your entire life running this company as a CEO or as a HR person, and you think you have an amazing culture, and then you switch insurance programs, and your pre-auths are different, and your pre-auths go from 5% to 15%, and now everybody who knows everybody who's sick in the organization is all upset. Your culture changes in a nanosecond because you didn't deal with your pre-auths the right way. All these things are intertwined and go hand in hand. I mean, health and wellness is a core requirement for your employees for you to be successful as a company. And if your decisions aren't aligned with your culture, aren't aligned with putting your employees in a position to succeed, you're going to have issues as an organization, and it's going to be more expensive. Now, your insurance company might come back and say, well, this is how we structured the cost, and this is our network, and this is but you've got to be willing to deal with that. Now, that said, there's still going to be times when the CEO doesn't want to deal with it, doesn't want to be the bad guy, and you're going to let your insurance company do that. Okay, it happens, and I understand that. But, the bigger picture is that pre-auth logic goes hand in hand with the culture of your organization.
So I think what I'm hearing is there's an opportunity to staff up human resources and benefits, particularly because, most folks, they just have the HR person may have 10 other hats that they're wearing in addition to benefits if they're a smaller company, or even a medium-sized company. Larger companies actually may not have enough staff to deal with all that you're talking about. So again, I feel like maybe staffing up chief.
I wouldn't necessarily say, I don't want to say staffing up, right? Because I think, it's just data, right? And it's just taking control of your data. And what I would tell you is you use more resources trying to chase your current situation than you would just having a chief benefits officer who does that work for you, or having one person or two people working for you. Because as every HR person will tell you, the time they waste talking to doctors, talking to the TPA and whoever's involved, or the insurance company, and getting the runaround, asking for data, taking control of all that and having it internally, or working with a different organization that's passed through, you're going to save so much time on that side of it. You'll be able to deal with it most likely without adding people, because that's the goal, right? No one wants to increase their bureaucracy, but when you have data, you can be better at making decisions. You can improve your culture, and you can understand the impact, as opposed to always chasing a third party who is not going to be completely forthcoming.
I agree. I think, there is a lot of waste, right? And we just need to maybe reallocate resources instead of.
100%. You hit the nail on the head, right? If you just shift them, if you can take control, right? So, and that's also the beauty of publishing your contract, because it seems like it's not intuitive to say, okay, we're going to publish our insurance and our pharmaceutical contracts, whatever they may be, put them on our website, next to all the other things we think are great about our company. Well, when you think about it, if you're able to look at other companies' contracts, you're going to get a lot smarter, a lot faster. If you're able to, that's why you have this organization, so you guys can all compare notes, right? And so if it's all published, because the first thing everybody says when you go to one of the conferences is, okay, don't tell anybody, because we're not supposed to tell anybody, right? And that's just, you're putting everybody in a position where they're breaking the rules of the contracts they sign, and that's even worse, right?
That's worse.
And so by just publishing it, you are making the industry smarter. And when you make the industry smarter, the BUCAs,
that's where the innovation comes in, right?
That's where the innovation comes in. Exactly right. And you put the big companies on notice that everybody knows the game. And now that everybody knows the game, you can't just say, well, you only got a 2% increase and everybody else got 7%, because I'm seeing everybody else got a 1% and you're just lying to me, and so it's just, you want that transparency. Sunlight is an amazing disinfectant, right? And that transparency would just be huge. And I get that it's a big step. It's a big step for an organization to say, okay, in our negotiations, we're going to require that they give us the opportunity to publish everything about patient data, all the numbers, all the the requirements that are part of the contract. We're going to publish it. And when that happens, the entire industry changes like that. More than any legislation could ever do, that transparency will change the industry.
So are there PBMs that are are there more than,
yes.
excuse me, 1 PBM, 2 PBMs that are allowing employers to publish their contracts?
Oh yeah. I mean, that's, Smith RX, Affirmed RX, Rightway, or 3 that come top of mind. They're definitely out there. I mean, we've used all of them and partner with all of them, and they're happy to. And, for our healthcare side, for my companies, we're out there talking to big providers and big hospital networks. And the first thing we say walking in the door is, okay, we want your cash price for everything. And we're going to publish the contract and doing it, but we'll pay cash up front for everything. You're not going to have any deductibles that you have to collect from employees. You're not going to have any co-pays or co-insurance that you have to collect. There's not going to be any claim denials, right? It's all, what you recommend. That's, we're going to partner. Your doctors are not going to have to, spend all that time on paperwork trying to get the pre-auths done. And they're like, let's go, right? Let's do a test. Let's try it. And so I really, direct contracting, there are companies that do direct contracting to help you create networks. And even if you want to use, like right now we're using Aetna's network, and we get charged $17.15 a month to use their network per employee. And that's okay, right? Even if you have to work around one of the work with one of the bookers, that's okay, as long as you have control of what's going on. But we're working to get to a completely direct contract environment so that we have complete control of everything that we do. And there are lots more companies popping up by the day that'll help you with all of that.
That's awesome. So direct contracts, it sounds like, is a future direction. I mean, you're there, but you're going to...
Oh, it's a current. Yeah, we're getting there, right? But we're trying to push it. And again, when we talk to the hospitals, they're like, well, we get a lot of business from the BUCAs, right? When they have tens of millions of lives that they cover, and we want that business. I'm like, well, there is some risk there, but when you start, when we start publishing what we're doing with you, and all these small to medium size and, not huge, but large companies see our contracts, they're going to say, oh, okay, I can do A, B, and C, as I see in this contract. Let me go to that same hospital network and work with them, in this city and that city and these cities. And let me work with their network, because I know exactly the best practices. Or, hey, Mark was really stupid about this thing in his contract. Let me tell Mark he screwed up here, here, and here. And I'll be like, thank you very much. And next time, because these contracts, typically only run a year, maybe 2, maybe 3 at worst. And you're going to be able to change very quickly.
I like it. So lots for all of us to think about. I really appreciate any final thoughts you'd like to share with folks?
Yeah, I mean, look, as self-insured employers, whether you're private, commercial, government, whatever it may be, you truly have the greatest opportunity to have impact on the healthcare system. If the big employers in the state of Indiana, and all the self-insured employers in the state of Indiana, started using only pass-through PBMs and publish their contracts, not only would you be a leader, you would change the healthcare for the entire industry. The missing ingredient in healthcare isn't the quality of healthcare, it's trust. Other than your doctor, nobody trusts anyone. And how do you build that trust? You publish those contracts. And the first company, no matter what size, you could have 50 employees or 5,000 employees, whoever starts it first is going to get the ultimate gold star of getting the credit for changing healthcare, not only in the state of Indiana, but the entire country. And that's really the opportunity here. Everybody in this audience has the opportunity to control their own destiny by taking a simple step that is in your best interest. Don't accept what the BUCAs and the big three tell you. Negotiate, negotiate, negotiate. Every RFP should include cost plus drugs. I have to say that. And you can go to, if you don't know cost plus drugs, please go to costplusdrugs.com. Put in the name of your medication. You'll see our cost. You'll see our 15% markup. You'll see our pharmacy fill fee. Shipping, if you want it mail order. We also have a pharmacy network so that if you want to pick it up, you can pick it up at a local pharmacy. All those things are available to you. And so the opportunity is right there. Healthcare doesn't have to be like it was last year in 2024 and 2025, and it's completely up to you guys. So, the future of healthcare in the United States is in your hands.
Well, thank you so much for your time today. Really inspirational to hear your thoughts and all those recommendations that you provided to folks. Good luck at the playoffs, and look forward to seeing you next time.
I appreciate it. Thanks for having me.
Thank you, Mark.
Thanks, Laura.